As a surgeon for a knee arthroplasty, we are concerned about the infection during immediate post-operative period, and we are concerned about dislocation in a hip during immediate post-operative period. Now, if you see the literature, it affects 1 to 2% of arthroplasty population, which has really not changed over the period of time. If you see on the right side, these are the old literature which shows same 1.5 to 2.5% infection, and the literature on your left side, which is of late, even after 20, 30 years, the rate of infection remains the same. May I have the mic, please? So, before we proceed upon, may I ask our panelists, honestly, what is your rate of infection? Let us start with Prof. Dr. Gevke.
It's extremely difficult to say, to be honest. So because we can only count our infections that we see again, and we cannot count the infections of our hospital that are treated abroad or outside. So of those patients we are seeing, again, it's 0.3%, 0.3.
Okay. Dr. Nagpal?
It's very variable, sir. So there might be a few months, 5 months, 6 months, 500 cases, you won't have any infection. And suddenly you could have 3. So overall, if you sum it over a year's time, it comes to around 0.5%.
So 0.5%, good. What is your rate of infection?
At my center, it is around 0.7%.
Okay. Neeraj?
0.5%, less than 1% for primaries. Revision, it is around 3%.
Okay. Kunal?
I would say less than 1%, let's say 0.7%.
Okay.
It might be between 0.5 to 1%.
So, if our panelists are honest, here the rate of infection is less than 1% in most of the cases. So, the diagnosis of management of PJI, we have to face the clinical challenges, you have to have collaborative multidisciplinary care, and you have to manage the uncertainty. So, I'll touch upon a couple of points only which are important from practical, point of view, and within the next 40 minutes. So first, an important thing, when you suspect a patient to, suspect an infection, you have reduced the time, no? It's 40 minutes in the program, okay. So, how reliable is your ESR and CRP? Let's start from that end.
ESR is less specific, it is somewhere around 70-75% specific, and CRP is more specific, it is around 85-90% specific for infection.
Okay, so for the diagnosis of infection, yes?
So diagnosis of infection, I would say the ESR more than 30 and CRP more than 10 is very sensitive and specific for joint infection. Though it can be high in chronic infection or cardiac disease, but for the sake of other criterias, I would say ESR more than 30 and CRP more than 10.
So that's for a chronic infection. What about acute infection, Neeraj?
So raised ESR and CRP, both is extremely
How much
important.
is raised in acute post-operative infection, say within 3 months after the surgery?
So early post-op infection and more than say 30 ESR, more than 10 CRP is highly sensitive, you can say, and specific towards infection.
Do you, depend upon your pre-operative ESR and CRP?
So generally we are doing pre-operatively, it's in a protocol, but it is reliable. Post-operatively, all of a sudden we will find the CSR and CRP higher side after around 3 weeks, then it's indicative of infection.
Dr. Nagpal, do you do in every patient ESR and CRP, and suppose it is high, suppose the CRP is 15, 20 or 25, would you worry? Or you will not operate?
Yeah, that's a protocol. For every patient, we do a pre-op ESR and CRP, and if both of them are normal, then only we proceed. Sometimes we have found rare bugs in patients whom they were elevated. So it's very key that before giving any antibiotics, we can actually take a culture. If you see symptoms of knee swelling or any other symptoms, like if you cannot relate the X-ray to the pain, sometimes it's a gentle X-ray looking, but the patient is excruciatingly painful. So that means something is wrong, there might be an infection. In such cases, it's always good to take a tap, get culture, get all the tests from the synovial. But they are actually quite good representatives of the infection.
Prof, if suppose preoperative CRP, ESR, CRP is high in a primary surgery, would you operate that patient or would you?
No, we cancel. So it depends on it. If it is around 10 or 12 without any reason, then we are going forward for the surgery. But let me state one. Both of them are not very reliable. ESR is a waste of time and money. We don't use ESR since 25 years in our institution. It's away. So you don't need it because it gives, ESR doesn't give you any additional useful information. And even CRP, 15% of the PGIs that we see when we publish this have a normal CRP level. So CRP is also not very reliable. But of course, if we see elevated CRP, let's say 20, 30, without a good reason, if it's, for example, if she is or he is rheumatoid arthritis patient, I go and perform the surgery, but if not, we always first look at the source of the elevation and then we operate, but not before.
One important point we need to take into consideration is after especially bilateral TKR, ESR and CRP remains raised for a couple of months, even in asymptomatic and those knees who are doing well. So it has to be correlated clinically.
Yeah.
Other factors are important.
So inflammatory arthritis, even an acute post-operative infection during 48 to 72 hours, if you want to do a marker, interleukin 6 is recommended as a recommended marker because it peaks in 8 to 12 hours after surgery and returns to normal in 48 to 72 hours after surgery. And especially the CRP will remain normal in low virulent organisms, and probably literature says D-dimer is a better marker in low virulent organisms. And this is some myths and facts about ESR and CRP. And CRP may be normal in about what Dr. Gerke told, that in 15% and to 30% of patient may be normal. So peak level of ESR is achieved in 5 to 7 days post-operatively, and it becomes normal in 90 days. And in acute infection, there is no consensus, whereas in chronic infection, if it is more than 30, then it may be significant. CRP rises 2 to 3 days post-operatively, comes back to normal in 3 weeks. And in acute infection, less than 6 weeks, more than 100. And in chronic infection, more than 6 weeks, more than 10 milligram per liter, probably it is, more, important to diagnose or, corroborative for infection. The next step, we go for the joint aspiration. So let's go, whether it's a OPD procedure, Dr. Nagpal, would you do it as a OPD procedure or you take the patient to the theater to do aspiration?
Always in an operation theater in aseptic conditions.
Okay, does it require a OPD procedure?
It is a OP procedure, not admission, but still in aseptic conditions.
Okay, so it can be done in OPD procedure, but you have to maintain that asepsis most of the time. Do you use ultrasonography, Neeraj?
No, sir. Never.
Never. So usually in knees you may not require, for the hips you require ultrasonography guided or a image guided, and you require to aspirate adequate amount of fluid like 10 ml. So do you send it in a plain ball, Kunal, or you use a EDTA ball?
Preferably a EDTA or a blood culture bottle, maybe. A blood culture bottle is more preferable.
No, if it is if it is a without blood tint, then preferable to use a plain ball. But if it's a blood tint, then you have to use a EDTA ball. Sometimes it may be blood tint, so you have to use the EDTA ball. What is your opinion, Prof?
It depends on the speed from the aspiration to the lab. So if you have a very short distance and only 1, 2, 3 hours in between, the best is to use a plain one. If you need more time or even overnight, then it's better to use culture bottles, and especially pediatric culture bottles. They are most sensitive ones, pediatric ones.
Okay, so what you send for, what you ask for in the laboratory when you send it to the laboratory?
So first of all, we ask for culture. That's for us the most important one, and then we ask for the serum, for synovial parameters. You have written it down. We We are not asking for CRP anymore. We are asking for cell count. It's not written here. We are asking for, and it's the most important part, PMN percent, polymorphonuclear percent. This is the marker with the highest sensitivity. So cell count, PMN percent, and culture. IL-6 does only make sense if it is a pre-septic situation, a very acute pre-septic situation. Alpha-defensine is not available in the most countries, in India not.
Yeah, it's not available here as well.
What we are always doing is leukocyte esterase test. But the leukocyte esterase test we do right after the aspiration. I show it later to you, and we don't send it to the lab.
Dr. Nagpal, what is your cell count level?
Cell count, if it is TLC is more than 10,000, more than 10,000, and if it's acute, then more than 3,000. So the percentage of PMNs is also very important. But when we send a culture, it is very important to also send an extended culture, because some organisms, it might be a slow growing infection. So up to 72 hours at least, some infections do come up after 5 days. Fungal infections can also take along. So whenever we send for cultures, it has to be extended cultures.
So your cell count in acute infection setting more than 10,000 or polymorphonuclear leukocytes is more than 90%, or in chronic infection more than 90 days, a cell count 3,000 more than 80% is one of the important parameters to diagnose infection. So this is of course in hip settings, which tomorrow we'll discuss. So if there is a metal on metal hips, these are the cell counts, and hip antibiotic spacers when it is there, when you are doing second stage, before second stage, when you are doing aspiration, these are the cell counts which has been described in the literature. So how often, Neeraj, you do all these tests, all these synovial fluid markers?
So we don't do it routinely. We ask for fluid analysis, polymorph number of neutrophils. So that is what we look into, and then aerobic and anaerobic. The point I would like to highlight here, how we transfer the sample. Sorry, I'm going back a couple of slides.
Yeah, we'll come there.
Yeah, because the microbiologists suggested us, if especially in periphery, we don't have these bulbs, and for anaerobic culture especially, so they suggested us to send the sample in a sterile syringe. We aspirate, we take out the air from that syringe, seal it properly and send it. So anaerobic culture also can be processed on same sample. So routinely we just go for fluid analysis, gram stain and culture.
Would you do all these, biofire test which is available in your city?
So biofire, we keep it standby. We give instruction, if you don't get bug in standard culture process, then go for biofire.
And what about next generation sequencing? It is available there?
So yes, it is available, but we don't suggest them routinely.
Okay. Prof, what is your, opinion about this biofire, multiplex PCR and NGS? Do you do it routinely in every case, or?
I mean, it's very, very marketing by BioFire. Multiplex PCR is not bad, it's quite good. The problem is that you can't get, you have written it down, the disadvantage, you can't get coagulase negatives and Corynebacter, and both are one of the most common germs for PGIs, and that's the biggest disadvantage. In my opinion, the future is NGS, next-gen sequencing, in the future, but of course availability is not extremely good. False positives are not really a problem, but the interpretation is a big problem, because you send your sample to the next-gen sequencing and you get back the result with about 8, sometimes 8 to 10 different causative germs.
Right.
And that's to interpret is extremely difficult, and we didn't find a way, yes.
Exactly. So all these, tests, if you see, the leukocyte esterase test can be done routinely in our setup, especially in Indian setup. It's easily available, it's done cheap, it takes just 10 minutes to do, put a drop of the synovial fluid, aspirate on the strips which are available, heuristics, which are available to see the urine sugar, so it can be done easily. And remember that the advantage is that even if patient has taken recently antibiotics, it doesn't affect that test. Synovial fluid CRP again doesn't get affected with the recent antibiotics, and important thing is in the inflammatory arthropathy where serum CRP will be high, that will affect the outcome, but in synovial CRP is high in presence of inflammatory arthropathy, even that may indicate the infection. BioFire is availability, cost is a issue, and remember certain organisms are not there in BioFire panel, hence if the patient is affected by coagulase negative Staphylococcus, Corynebacterium species, then this show will become negative because it's not there in the panel itself. And NGS is very limited availability, it's only available in couple of cities here in India. There are high contamination rates, so there is a possibility of false positives. And what Dr. Gerke told that, the interpretation is extremely important in NGS test. However, interleukin has got a sensitivity and specificity of 100%, but hardly it is done in our cities. Now next we come to diagnostic criteria. There are various diagnostic criteria, MSIS 2011, 2013, the ICM 2018 criteria, there is a European Bone and Joint Infection Society criteria. So which criteria do you follow to diagnose your infection? Let's start with from that end. Yes, sir.
The first thing is the clinical, and if the pus is, the sinus is draining, it is confirmed infection. And two positive cultures, that is again a confirmed criteria for infection.
Yeah, so that is important. That criteria remains, the main criteria in all these classifications. So if one of these, sinus tract communicating through prosthesis or two cultures showing the same organism, there are two important criteria which is common to every classification. So we do not require any, laboratory test to prove that this joint is infected. Now remains the rest of the minor criteria which you have already discussed about synovial fluid, WBC, and all the cell counts. Now how will you improve your culture yield? Yes, sir.
One comment regarding the definitions. There is no perfect definition yet. Now we are working with the best microbiologists and infection disease specialists all over the world, mainly with US and Europe, on a world unified classification. During the ICM, we will come up with a completely new classification, which is a consensus of all the important microbiologists in the world.
Okay. Anything different from this classification?
Slight differences. Not really big differences, but some slight differences.
Okay. How to yield the culture? Yes, Kunal.
The most important thing, to have an antibiotic-free period before taking the culture. A 2 weeks antibiotic-free period, preferably in a aseptic condition, in a culture bottle, and ask the lab to incubate it at least for a longer period of time, say 14 days, and have aerobic, anaerobic, fungal, all the cultures possible.
So routinely do you do fungal culture, Dheeraj?
Yes, we ask for that. And we ask for extended incubation, that is necessary. Say in some patients you get the yield or bug after 3-4 weeks also. So that is extremely important to ask for extended culture.
Prof, anything different, how to improve the culture yield other than what is mentioned here, that what we have discussed?
No, it's perfect. It's perfect.
Okay. So at least 2 weeks stop the antibiotics, and you need to send multiple samples. And remember that incubating the samples within 2 hours of sampling will, culture yield will be much better, or it will increase the yield of the culture. And you do extended culture until about 8 to 14 weeks. Do you do sonication of the implant when you are doing a 2-stage or 1-stage reconstruction? Any of you? Anybody in the hall do the sonication of the implants? Okay. Prof, you do sonication of the implants? Dr. Gerke?
Sonication?
Yeah.
No, we don't do it. So, sonication is, as we know, we mainly always use one-stage exchange. If we go for a two-stage exchange and we do not know the germ, then we send the implant for sonication actually. But not on a regular basis, but if we really want to know what the germ is, we explant the prosthesis and send it for sonication. It gives you some additional informations and very, very often the identification of the bacteria.
So remember that, all the cultures must be biopsied, all biopsies must be cultured. So it is a tissue sample which is sent for, biopsy, and in our country especially, tuberculosis is important, and fungal culture is important, especially patient on immunosuppressant medications, diabetic patients who have history of any malignancy. So these are the patients, or patients on long-term antibiotics even, fungal cultures are important because there is super infection with the fungus. Sonication, most of us we don't do, but sometimes you can do a sonication wherever it is available, whenever there is a two-stage reconstruction, and there it shows that there is a higher sensitivity for culture of sonication fluid. Next we come to the treatment part. So when you do a debridement, when you retain the prosthesis, what is your indication of debridement?
In acute infection, which is presenting less than 4 weeks, we can go for debridement, antibiotic and implant retention, where we exchange the poly and we do complete debridement, and then postoperatively we continue.
In late infection beyond say 4 weeks, what you do DAIR or you do a two-stage exchange or one-stage exchange?
Mostly two-stage revision, but there are number of different things which needs to be assessed before taking a call for two-stage or one-stage. But in acute it is always there, we make an attempt to retain the implants.
So it's recommended that in early postoperative infection less than 3 months of the index surgery, or in late hematogenous infection within 3 weeks of onset of symptoms, when the implant of course is well fixed, then DAIR probably done. And these are the indications of best results of doing a DAIR. When you should not do DAIR, yeah, Prof, you wanted to tell something.
Yeah, we are a little bit different. So early postoperative infection, joint age, 3 weeks, not 3 months in our hands. And you mentioned it, short duration gives us the best results. Late hematogenous, we never do there because nobody knows when the infection really started. It can be completely independent of the symptoms. So nobody can say the symptoms started exactly on this date. So we don't do it. And there's worldwide another tendency, another trend now, that is that nobody does DAIR anymore. They do the one-stage exchange, especially if they have cementless implants. You can get it out quite quickly. And so more and more surgeons all over the world perform a one-stage exchange instead of a DAIR, because it's easy to perform. You get the implants out easily, you can clean everything behind the prosthesis, and then the success rate is much higher.
So in the cementless implants, we don't see much of cementless implants in our country. So in cementless implants, the single stage exchange becomes easier. So these are the contraindication of doing DAIR. Whenever there is a sinus tract present or when there is a loose prosthesis in the X-ray, then avoid doing a DAIR. And these are the conditions where DAIR will give you a poorer outcome. So what Dr. Nagpal, when you do a DAIR, anything extra you do in the irrigation fluid, you add anything, or what is your method of doing DAIR?
We use everything. We can use a betadine, peroxide, maybe put in some vancomycin powder, wash it with linezolid, metronidazole, everything we can just use. And always we can sometimes put in some stimulant beads as well, and change the poly if it is not all poly.
Yeah. So in addition to that, whatever Dr. Nagpal has told you, that you need to add one anti-biofilm agent to the DAIR. Either acetic acid, benzalkonium. Normally we add chlorhexidine to this fluid, normal saline, as an anti-biofilm agent. And always we put local antibiotics, calcium sulfate pellets, like stimulant, which is available impregnated with antibiotics. This is one of our patients, 56 years, female, bilateral sequential total knee, left knee got infected. That is after Dyer procedure, 4.5 years free of infection, that is before surgery, and this picture is after surgery. Yeah, Neeraj.
For Dyer, biofire works actually. We aspirate, we send it, we get the report, we involve ID consultant, we decide what antibiotics to be mixed in a stimulant. That really helps. And then we proceed with Dyer procedure, because we should know what antibiotics to be mixed in stimulant. That is extremely crucial before we take the patient to OR.
Do you use any scoring system to assess the success of your Dyer?
No.
Anybody uses any scoring systems, Prof?
There are existing two scoring systems, a click score and the other score is both from Spain, click score and crime score. Both of them are from Spanish authors. We take it in consideration, but at the end we don't use it.
Yeah. So that has been described in the literature. For acute PJI, use this click score, and for the late acute periprosthetic joint infection, crime 80 scores will tell you these are the predictors of success. Of course, nowadays AI-induced predictors of success are coming up. I think it is not much in use right now. Next important things, let's talk about antibiotics. So antibiotic is especially involves is first parenteral phase, then second oral phase, next further suppression or continuation phase. So which antibiotic, how long, IV or oral, do you involve a microbiologist, ID specialist? Let's start with from that end. We'll come to Prof later on to have a consensus.
The initial phase is we start with IV cephalosporin, first generation cephalosporin. Cultures are important and minimum 2 to 4 weeks of IV antibiotics are to be given, and then followed up by oral antibiotics for ranging from 4 to 12 weeks.
4 to 12, this is after the Dyer or after the two-stage exchange or first-stage exchange?
It would be like after Dyer also, or if it is just two-stage revision, then in that case after first stage continue with this protocol of antibiotics, discontinue the antibiotics, wait for 2 weeks and then do second stage revision.
Kunal, do you have any difference in the Dyer procedure and two-stage exchange procedure? Your duration of antibiotic, continuous IV or oral?
With the advent of a stimulant, I guess we can decrease the IV antibiotics, and especially we have to remember that more than 50, if you see the evidence, more than 50% of the organism is staphylococci. So the study says, so the empirical treatment should be according to the staphylococci and gram-negative bacteria. So 3 weeks of antibiotic is enough.
So do you involve a ID specialist?
Yes.
Okay. Neeraj, what is your duration?
So we should always involve ID specialists, first thing. And their regimes are different and they really help. That's our experience.
So
and
the
couple of weeks based on the bacteria, age and other comorbidities also, they decide 2 to 4 weeks of IV followed by oral antibiotics. So that is extremely important. So that's how we go in all PJI cases.
Prof, what is your protocol?
After Dyer, you mean after Dyer or?
Yeah, after Dyer, after one stage, two
yeah.
stage.
Usually it's a little bit different. First of all, again, you have to follow the recommendation of the microbiologist, because as a surgeon, we don't know too much about it. And so we go for 2 weeks IV and then for between 2 and 3 months parenteral oral. It's depending on the germ. For example, streptococci, they need probably 1 year sometimes, and some others need only 6 weeks. So it's really depending on the germ, and that's it. 2 weeks IV, and then let's say between 2 and 3 months oral.
Oral. Okay. Both after Dyer and the one-stage exchange.
Yes.
So these are the antibiotics, remember, for intravenous infusion in periprosthetic joint infection, which has been recommended in the literature. Of course, it depends on the organism. Always you need to have a joint committee of orthopedic surgeon, microbiologist, as well as infectious disease specialist, because they select the antibiotics which will be most suitable for the host and most suitable for that condition. So after the intravenous antibiotics, these are the oral antibiotics which are recommended especially for periprosthetic joint infection. And again, it depends on what is the target organism, and depending upon that, they continue with the oral antibiotics.
Only
Now,
5 minutes.
how long to continue? So this is a Infectious Disease Society of America recommendations. If you are, this of course little old, it's almost more than 10 years old. If you are doing a diet in hip periprosthetic joint infection, 3 months continue with the antibiotics. And if it is staphylococcus, use a rifampicin based combination of antibiotics. And if it is knee, you need to continue about 6 months of, antibiotics. Whereas if you are doing one stage exchange, both and hip knee joint, you can continue up till 3 months of the antibiotics after the surgery. There is a Dartiport trial, duration of antibiotic protocol after periprosthetic joint infection between whether to continue 6 weeks or 12 weeks. In Dyer, they have recommended it requires 12 weeks, either, plus or minus oral suppression afterwards, whereas in one stage it is 12 weeks, and in 2 stages it requires 6 weeks of antibiotic, then leave a gap for about 2 weeks or 6 weeks, and after reimplantation again 2 weeks to 3 months of prophylaxis. So this is the antibiotic protocol which needs to be continued. Next we come to what is the treatment of culture negative PJIs. What is your recommendation, Prof?
In culture negatives, we always, I will tell it again tomorrow again. So first of all, repeat the aspiration. If you get no germ again, then take an open biopsy. If you don't get a bacteria at all, go for a 2-stage exchange.
Okay.
That's our protocol.
So anybody who has got any specific antibiotics for culture negative periprosthetic joint infection?
So we do it very broad. We give a very broad spectrum until we get the germ after the surgery. So usually you can use imipenem, meropenem, but that's a big danger. Imipenem and meropenem has an extremely wide spectrum, also with against the gram negatives. But the danger worldwide at the moment is it's one of our last resources, and we see more and more resistances against this antibiotics. So don't play it with it too easy.
Okay. So the literature shows that with a study of 556 surgeons and the combination of vancomycin and fluoroquinolones or ceftriaxone or cefepime is the combination of antibiotic which is used in culture negative PJIs until 6 to 8 weeks of duration, and 2 to 6 weeks you give vanco plus quinolones or cefepime, and followed by 1 to 3 months or levofloxacin with combination of either rifampicin, doxy or amoxicillin or cotrimoxazole. Now antibiotics in bone cement, what you add in the bone cement, whether pre-mixed, add extra antibiotics, which antibiotic, liquid or powder, how much, and how to mix. Yes, Dr. Nagpal.
So it's always better to have a pre-mixed, but vancomycin, whichever is the powder form, is always better to add. Don't ever
How much
add,
you add?
Up to 2 grams of vancomycin. Never add a liquid because that will hamper with the cementing.
So due to shortage of time, I'll just quickly go away. So these are the low dose and high dose antibiotics which can be added to the cement. So low dose means when you are using for the primary fixation of the components, high dose when you are using it as a cement spacer. So when high dose antibiotic means you can add until about 20% volume by volume antibiotic powders to the cement for better elution of the antibiotics into surrounding structures. Quickly we just next 1 minute, 1 stage or 2 stage exchange. Anybody does a 1 stage exchange? Anybody in the audience, any delegates, 1 stage exchange? Do you do in the hip or knee or both? Yeah, there are certain criteria. Yes, Bill? So you do both hip and knees. So 1 stage exchange, shows a superior functional outcome, though 2 stage exchange, has got a less adjusted risk of reinfection, hence two-stage remains the gold standard. So if you see the literature, two-stage revisions has got greater success rates than one-stage in knees, periprosthetic joint infection of the knee, whereas in the hips, it has got almost equal one-stage or two-stage. The meta-analysis shows there is no difference in the reinfection rates between one-stage and two-stage, whereas most of the American surgeons, Clive Duncan's paper in 2023 shows that preferred two-stage in the, especially in the knees. And one stage, as you know, they told that no signs of systemic sepsis, microorganism is isolated, there is no sinus, especially in the knee. In the hips, if a sinus is present, they prefer the one stage, and reinfection rate is 0% and minimum of 3 years by Paris Haddad. And Clem et al., they have reported that a higher patient-reported outcomes in both one stage and two stage. Now, Endoclinic has got a largest experience of one stage, revision. The infection-free survival at 10 years is 93%, Prof. Gerkek's paper. So we'll listen more about in his lecture about one stage or two stage. We'll leave the spacer part. So to conclude, dear friends, ESR CRP, has got a more of a prognostic value rather than a diagnostic value. Synovial fluid markers, leukocyte histories is a must. You can do all of you can do CRP and interleukin you can do. In culture negative, look for the tuberculosis, fungus, do a multiplex PCR or next generation sequencing. MSI's criteria for diagnosis of infection. In dire, you require a meticulousness, you require an anti-biofilm agent to add to the normal saline, and do some form of local antibiotic delivery which will be complementary to our intravenous antibiotics. And antibiotics is now recommended until about 6 to 12 weeks, and involve your ID specialist while giving post-operative antibiotics after dire or a one or two stage exchange. And two stage scores better with articulating spacers, especially in the knees, whereas in the hips, both one stage and two stage, they perform equally well. And in the hips, there is no difference in the one stage or two stage. I thank you for a patient hearing.